a lot of patients with spinal cord injuries. Today we have as a faculty Dr. Nitha. Dr. Nitha is a physical medicine rehab doctor who completed her MD from CMC Vellore. She was working in the department of PMR at Sri Chitra Institute of Medical Sciences, and now she's a consultant at KIMS Hospital, which is the hospital situated in Trivandrum, Kerala. And I understand she has a lot of work done in stroke rehab, and she is even part of handbook released by Sri Chitra Institute on stroke rehab. I think that's the need of the hour. Actually, so many patients are confused how to go ahead with their lives after a stroke. Yes, we heard from Dr. Shrikant last week on stroke rehab, a little bit of rehab on neurological illness. Thank you, Dr. Nitha, and yes, she's trained in palliative care. So that has an added advantage that she understands the context really well than many others. Thank you so much, Dr. Nitha, for agreeing to be part of this program and for just agreeing from the beginning. I think we spoke about it months back, and yeah, it's happening now. Thank you so much.
Thank you, Sridevi, ma'am. Can I start or?
Yes, we can start.
I'll just try to share my screen first. Is it visible? Is it visible?
Yes, it is visible. Yes, it is.
Okay, good afternoon all. So we are going to talk about spinal cord injury. I have been asked very specifically to talk about neurogenic bladder, bowel and sexual rehab. So I will not be talking much about spinal cord as such. So we'll just brush on rehabilitation goals of spinal cord injury, then a little bit on neurogenic bladder, bowel and sexual. So you all know what is paraplegia and tetraplegia, right? Can this be an interactive session? I would prefer to have some answers. So what is the highest level for a paraplegia? Anyone can answer, please?
Anyone in the chat, or you can unmute.
Thoracic level D7.
Okay. When you talk about tetraplegia, all four limbs are affected. So if the upper limbs are spared, then it is paraplegic. So the highest level of paraplegia will be T2. Anything from T2 and below is paraplegia. Okay. So when we talk about high tetra, it will be like C1 to C4. And low tetra will be like C5 to T1. Anything below T1 is para. And high paraplegia will be like T1 to T6. Anything below T6 is low paraplegia. Okay, this you all will be knowing. What are the problems with paraplegia, or like what are the domains which is affected? One is weakness, second will be the sensory involvement, third will be spasticity, then bladder, bowel and sexual issues. What are the added things when it comes to a tetraplegia? Other than this, what will be affected? So they will have respiratory insufficiency, hand functions, as well as ADL dependence. Okay, we'll just take two clinical scenarios just to explain on rehabilitation goals. Okay, this can be interactive. So we have a 28-year-old who had a road traffic accident and who is T12 complete paraplegia, who had finished his BTech and he is working. And he's from a low socioeconomic status. So as a physical therapist, what will be your rehabilitation goals for this patient? Can someone unmute and say, or put in the chat box? Or it's a simple question. Anybody can answer.
Ma'am, we need to make the person functionally independent in this condition. And
That's true.
like, yeah, short-term goal will be like we need to go for a strengthening of the muscles, and if at all, in case if there is any tightness of muscle is present, then stretching has to be done, then balance exercise, and also like since it is T12 paraplegia, so there not be much, I think, problem with the patient. Low level paraplegia is there. So if at all orthotic assistance is needed, then we can prescribe the same according to the level of the injury.
Okay, so he is a T12 paraplegia. Will you make him, what will be your mobility goals for him? Can he be independent? Can he have independent mobility?
Ma'am, he'll be able to move independently only with the assistive devices.
Okay, so what are the assistive devices you can think about for T12?
Orthosis,
Like?
HKFO.
Okay. Okay, so we'll see the, so for me, the rehabilitation goals first will be instrumented activities of daily living independence. That means T12 will be independent in most of the daily activities, but he should be able to do all the instrumented activities also. And his independent mobility, as you said, with orthosis and aids. So when it comes to T12, it is very difficult to actually walk with HKFO. So if we can free that hip and just give a KFO and bilateral elbow crutches, he'll be more mobile. Along with that, they should be trained on wheelchair mobility also for quick transfers and maybe just going to the bathroom and all that. Okay. Then will be the neurogenic bowel bladder management, sexual activities, and resumption of job, along with community reintegration. Okay, in case 2, we'll have another scenario. Here we have a 77-year-old female who is a case of CA breast with dorsal vertebral mets. She is a T4 incomplete paraplegia. She has a grade 4 pressure ulcer with congestive heart failure and pulmonary embolism. So what can be her rehabilitation goals? I think this will be more towards like palliation, right? So what functional recovery or like what functional independence can we bring in this female? Anyone else?
Ma'am, since it is a case of metastasis at the dorsal vertebral column, so we should we need to avoid the vigorous strengthening program in this condition. Otherwise, it will lead to pathological fracture in this person or in this patient. And like if suppose the patient needs some assistive devices, then we can give some form of spinal orthosis in this condition. And since the patient is having grade 4 pressure ulcer, then if we want to use some modalities, then high voltage pulse galvanic stimulation or zinc oxide iontophoresis will be more fruitful in this condition for treatment of the pressure ulcer.
Okay, right, Vandana. Thanks a lot for that. So for her, the first and foremost thing will be the pressure ulcer management. And second thing will be, as you told, will be the spinal orthosis. When it comes to grade 4 pressure ulcer, most of our conservative treatment will not work. And surgical will be the choice actually. But according to Sridevi ma'am, most of the times we will not be able to do surgical closure. In most of the tertiary care hospital, actually for grade 4 ulcers, in spinal cord injury, with a good plastic surgery department, we can do a flap cover. Then the next thing will be give them independent mobility. We may have to depend on a motorized wheelchair, or we can use the manual wheelchair also since it is T4. But considering her other comorbidities, we may require more electrical assistance. then prevention of infections, ADL dependence, and add more quality years. So this is in nutshell just about the rehabilitation goals. Now we'll come to the topic proper, that is a neurogenic bladder. So bladder means the control of bladder is from the frontal cortex. We all have social inhibition, right? Whenever we want to avoid, then only we are avoiding. The center is mainly in the bones, and the reticulospinal tracts carry the information. So this is just for your info. Normally we have the pontine storage center, which will be active, and with this we have the pontine storage will be stimulating the sympathetic chains and will have the detrusor inhibited. So we can have more storage. So this will stimulate the pudendal nerves, and that will result in external sphincter continence. So once we want to void, there is a switch from storage to the voiding reflex, which is also situated in the pons only. I'm not going into detail in this one. This is just to show you that the bladder wall has detrusor muscle. Okay, and for the male bladder neck has prostate. You all will be familiar to this picture. It's just to brush. Neurogenic bladder management is a vast topic. So how we do is like we classify the bladder according to the Mader-Basher classification. You all had seen acute spinal cord injury, right? So the patient will be how they will be managing their bladder in acute spinal cord injury or during spinal shock. Anybody can say?
Indwelling catheter.
Yeah. So what are the types of indwelling? It will be a continuous bladder drainage through an indwelling catheter. So what are the types of indwelling catheters? So we have normal Foley's catheter, which is actually coated latex, and we have silicone catheters. Everybody is familiar with the catheter, right? Okay, the advantage of silicone catheter is it can be kept for long time, like it can be kept for 3 months. In which Foley's catheter we hardly use for 2 weeks, even if it is stretchable for 3 weeks to 1 month. So as you all know, male urethra is when you insert the catheter will be like an S shape. It's difficult to catheterize males when compared to female, as female ureters is very straight and it's very easy. Likewise, the chance of infection is also more with females. So when you go to the houses to see the patients with paraplegia in the acute phase, most of them will be in an indwelling catheter. So what are the complications that you can see, or like what are the complications they will be sharing with you? One can be an infection. So they will present with a lower abdominal pain. If it is incomplete, they will say that there is dysuria or there is pain in the perineal region. There can be foul smell in the urine. So if at all you see these symptoms, what can you do or what can you suggest? So you can suggest them to take more oral fluids. And if with that also it is not coming down, it's better to refer to a doctor because UTI has to be treated. It will require medications. I'm not detailing any medications in these slides. Second is like the patient will be on dwelling catheter and they will be having pericatheter leak. That is leak around the catheter. So what can be the causes? You make the patient stand and the patient is actually leaking around the catheter. So one thing is that it may be a blockage. If it is a blockage, you just need to flush the catheter. How will you flush the catheter? Anybody? Other than Vandana?
We want to hear from you all. You can't just keep quiet because you are people doing this almost or dealing with such patients almost every day. So we would like to hear from you. Or I can call names. I'm shameless. I can call names. Dr. Shruti, would you like to comment? Did you actually hear the question? Sorry.
Okay, if there is a pericatheter leak, like you make the patient stand or do some exercise and there is leaking around the catheter. The catheter is in situ, but the patient is still leaking. So then what you will do or what you will tell the patient? They will be really embarrassed with that situation. Okay, so the most probable thing will be a blockage. The catheter may not be draining. So flush the catheter. Flush the catheter means take some 20 ml of saline or like whatever syringe you have. You can disconnect the disconnect the euro bag and just push with some force that 20 ml saline into the bladder. You got it or okay? So try that maybe 2 or 3 times. Most of times with that itself, with that itself, the problem will be solved. Another possibility is that the catheter may be of a smaller size. If a larger dimension, larger French catheter is placed, it may decrease. If still pericatheter leaks are very common, then it has to be seen because it can be a spastic bladder or it can be an incompetent bladder neck, or maybe there is an underlying urinary infection which is resulting in a irritable bladder. So in that scenarios, you need to be treated and the patient has to be seen by a physician. Okay, paraphimosis. This is a very common thing. Most of the times, people put the catheter and they won't retract back the foreskin. They won't replace the foreskin. It will be in a retracted position. So what happens to the retracted foreskin is there will be swelling and edema around the retracted foreskin and it can become infectious. So always, whenever you see a patient in CPD, if the foreskin is retracted, ask them to replace it in the original position. If it cannot be done, then we may have to put some small punctures or surgically release also. This is something which is very avoidable actually. Okay, you do some exercise and the patient is having a hematuria. What do you do? It can happen, right? Okay, if it is some single episodes or 1 or 2 episodes, the most probably it will be like a catheter pull. Because of the position change, the catheter may get pulled and that will cause some microtraumas inside the bladder, which is resulting in hematuria. So in that case, always make sure that the catheter is properly sticked. It is not being pulled. There is no tension in the catheter. If there is recurrent episodes of hematuria, have to refer to a physician because it can be either a UTI or there can be bleeders or most of these patients may be on anticoagulants. So it can be an anticoagulants induced also, or there can be an underlying renal stones or a bladder stones. If you see a lot of sediments or if the patient is complaining to you that there is a lot of sediments in the urine, so what can be done? Here tell them that if you have more sediments, there is chance of catheter blocks is more and the probability of infection is more. So it is better to increase your fluid intake. And if that sediments is leading to foul smelling urine and signs of urinary tract infection, then it has to be treated. Otherwise, normal sediments, you can just leave it like that. But it can be a what do you say, the first signal for UTI. Okay, if urine is not draining, what can be the common thing? You had gone to a for the palliative home care, you had seen a patient. They are telling that urine is not being drained for the last 4 hours. You are the only healthcare worker they have access to. What you will do? Anybody? It's a very common scenario. Okay, so
Ma'am, hot fermentation will help in this condition if the patient is not able to drain the urine out. Hot fermentation over abdomen.
Yeah, that is something which can be tried. But you have to understand that here there is an CBD, there is an indwelling catheter. You're not talking about any bladder neck or anything. So hot fermentation is not going to help when you have an indwelling catheter. So here first you have to see whether the bladder is full or not, whether there is a palpable bladder, whether there is a retention of urine. If the urine is retained, that means either the catheter is blocked. Most probably the catheter is blocked. So flush the catheter and see. After flushing also, there is no draining. Then change the catheter. Maybe it's like a lot of sediments are there. Even after flushing, it is not getting opened. So change the catheter. After changing also, there is no urine. That means what? That means the patient is anuric. For the last 4 hours, the kidney has not produced urine. So that is something which has to be taken care. So that patient has to be referred. Okay. Hot fermentation works when we have self-voiding, not when you have an indwelling catheter. So what I mentioned right now is like when somebody is having an indwelling catheter, what are the common problems that they will face or that they can share with you when you go to their home? And what are the simple things that you can look for? Okay, now coming to the subacute phase or like after the early phase of spinal shock, how do you manage a neurogenic bladder? See, management of neurogenic bladder is beyond the scope of this class. So what I'll do is just explain some common things that you can take care. So this is just an like how we do the evaluation. Evaluation depends on the level of like we'll be looking on the level of the lesion completeness, bladder sensations, a detailed urodynamic study, then ultrasounds, hand functions, sitting balance, and the upper tracts. With this only we will decide how to proceed on the management of neurogenic bladder. So clean intermittent catheterization. Can anybody explain what is clean intermittent catheterization? Everybody is familiar of this terminology? Someone?
Ma'am, when the patient is having urge, then only the patient himself will going to catheterize himself to void out the urine.
Okay, you have a T12 complete paraplegia who will never have any sensations of the bladder. Is totally complete. So should he be in an indwelling catheter lifelong?
No.
Yeah. So then the option is clean intermittent catheterization. So the name itself is self-explanatory. So it's a clean procedure. It's not a sterile procedure. So when we do catheterization in a hospital, it is an absolutely aseptic, sterile precautions. But in clean intermittent catheterization, you are just cleansing your hands and make the surroundings clean. Okay. The perineal areas will be clean, hands will be clean, the catheter will be clean. And as the name says, it's an intermittent. So between two catheterizations, the patient should be continent. That's what clean intermittent catheterization is. If anybody didn't understand, wants me to explain more, I can. Anybody wants to know more about clean intermittent or understood?
Have you all seen or have been doing clean intermittent catheterization? You can just raise your hands.
I cannot see others, sorry. So
Priyadarshini, have you seen clean and intermittent catheterization?
okay, we'll move forward. So what are the complications of a clean intermittent
There is a
catheterization?
chat,
Most
Dr. Nitha.
okay,
Megha is
sorry.
asking.
Ma'am, I don't know how to access the chats.
Maybe when you are presenting, it's slightly difficult. I can read for you. It's just a little bit more about clean intermittent catheterization.
Okay. So clean intermittent catheterization, it is the best option right now if you are a complete paraplegia or a complete tetraplegia, and if you want to get out of the CBD. So what we do is we'll use either you can use a Foley's catheter, can use even suction catheters also, any catheter or any tube which you can use to drain the bladder. Here what the clean concept is like, you have to wash your hands, wash your perineal areas, keep the catheter, whatever catheter you are using, clean. So how we keep it clean is like, always before catheterization, use soap and water, clean entire things. And after the procedure, it has to be cleaned the same way, and you can air dry it and keep it in a, either you can keep it in a, what is it, some cloth pocket like thing, cloth bags, which is specifically designed for this. Or in Pallium India, actually, we are telling even metallic boxes also, ma'am. I think so.
We give them the metal
Yeah.
trays with the lid.
Yeah. So both can be used. The advantage of cloth bag is like you can take it everywhere. It's easier to just insert in a pocket or insert in a bag and all. And like Follies and all, you can use it for 2 weeks or till the color changes. But beyond 2 weeks, it's very difficult. Then how often you have to do? Like Vandana told, for patients who has sensations, who can feel their bladder but who cannot avoid, for them we can put according to their urge. Like whenever they have the feel, they can just put it and take the urine out. Others, if we can get a 3 to 4 hours of continence, that will be good. 4 will be something ideal. So in each clean intermittent catheterization, what we are targeting is between the catheterization, there should not be any leaks, and each catheterization, the volume should not be too much. Something which is not beyond 500 ml will be like arbitrary 500 ml will be adequate. I hope it's clear. So what are the complications these people will be facing or what they will be sharing with you? One is frequent leaks. They are doing clean intermittent catheterization, but still they are having leaks. One may be a stress leak, like they will have a cough or anything which increases the intra-abdominal pressure can result in leak. So in that scenario, we have to see the tone of the bladder neck or the sphincters. They may not be patent. They'll be lax. Because of that, it can have frequent leaks. Another thing is that it may be a spastic bladder, retros or overactivity, which will resulting in frequent leaks. All these, like this needs to be addressed by a physiatrist or any specialized physician in this. Another important thing is bladder stone. What can be the cause for bladder stone? You don't get bladder stone that common, right? Renal stones, yes, but bladder stones are very not so common. But in these people, bladder stones are more commoner than renal. Can anybody guess why? Most of the times when you insert the catheter, if it is not clean, a small pubic hair can go inside. That small pubic hair can be the nidus for the stone. So we have to be that much clean when we are doing this procedure. So bladder stone also, it has to be taken out. It can be either do it cystoscopically or open depending on the size. Then because of the multiple urethral punctures can result in urethral stricture. Because these pathways are not suitable for putting and taking out. It's a natural pathway. So multiple times when you put the catheter and take out, at times it can result in urethral strictures. So that also needs medical attention. Sometimes it has to be dilated. Sometimes surgical procedure is needed. Sometimes you have to find another route. You may not be able to use this route. You may need to go for a suprapubic catheterization like that. You can present with ulcerations. CIC not properly done can result in recurrent infections. If the Yeah, recurrent infections are there, then we have to go back and see the cleanliness, the technique. Maybe just need to uh, shave out the pubic hair, and definitely recurrent infections needs medication. Another thing is hydroureteronephrosis. This happens when, like, if they forget to do the CIC and there is like 6-7 hours and the bladder volumes are high, then back pressure can happen, and even the ureter as well as the kidney can have bulged out with the hydroureteronephrosis. That is mainly when the timing is more, or if there is a spastic bladder, back pressure can happen. So I have told a lot of complications. Then why should we do a clean intermittent catheterization if these many complications are there? Isn't CBD more easier? Anybody?
I think I have asked that question personally many a times. Isn't it better to do CBD? Because the effort that they take every 3 to 4 hours and the training, intense training needed. But I think once they get used to the routine and they find it really, really helpful.
Yeah. Once somebody is trained in CIC, they won't go back to CPD. I have never seen a single individual going back. Unless they are like, if there is complications like fissures and ulcerations and all, medical indication will be there. So first and foremost, continence. Like that 4 hours that they are not doing, or whatever hours that they are not doing, at that time, they are continent. That's the first and foremost. And aesthetic. Most of us doesn't want to walk with it. Even if it is a leg bag, we don't want to walk, right? Second is you are actually not blocking the sexual pathway. If it is a clean intermittent catheterization, they can have a sexual intercourse more easier than a have with a CBD. Just a briefing on external collecting devices. Just some. Uh, do you know what is this? The second, the left down picture. Can anybody say? This is something which we use very common.
Urine bag.
Yeah, this is a urine bag. What is this connection?
It's a condom catheter.
Yeah, it's a urocondom. Some people, we may not be able to do CIC. One thing, maybe it may be painful if you have a sensory intactness, or if you are incomplete. Second thing, the bladder neck will be so loose that it cannot hold any urine as such. You may need to surgically reconstruct the bladder neck, which is not possible right now in most of the centers. So sometimes we have to depend on urocondom. And even at nights also, if people doesn't want to do CIC, if it is incomplete, they can go for urocondom. These are the other collecting devices. This is some nylon undergarments fitted with not condom, something similar to condom like thing. This is the female one. Okay, another common thing that the patient will be telling is in the urine they had seen sediments and they feel that it is semen. So in that scenario, what you will say? You are the only healthcare worker available. It needs to be addressed. Okay. If fertility is not a issue, then retrograde ejaculation is fine. In the sense that most of the people will be having retrograde ejaculation, you just need to reassure. If fertility is an issue, then things are different. Okay, you had gone to a maybe T4 paraplegia. You tried to do some exercise. The patient is complaining of headache. What you will do? This you have to answer. Sridevi ma'am, you can call out some names. I really need an answer. While doing therapy sessions, T4 complete, complaining of headache, severe headache.
Very, very important and very common scenario, right?
Yeah.
Anyone?
You must check the blood pressure in case.
Yes.
Sorry,
Sir.
yeah, because it might be life-threatening also in case because during intercourse the blood pressure will rise. There's this area of concern.
I just heard we have to check the blood pressure, but I think there is some disturbance.
Yeah.
Ma'am, it may be due to postural hypotension also. We need to ask the patient to lie supine and raise the leg.
Right. So what are the two commonest things that you have to think if there is a T4 complete paraplegia complaining of headache? One can be postural hypotension, one can be autonomic
The
dysreflexia.
autonomic dysreflexia. Yes.
You have to think about both. You have to think about both because the management is different for both. So how will you differentiate a postural hypotension from an autonomic dysreflexia?
In postural hypotension, the blood pressure will fall by 20 if you change the position from the spine, sitting and sitting to standing, and diastolic will fall back down.
Yeah, if there is a low BP,
The position will
the
be
probability
different.
will
Not
be,
make the patient.
if the BP is low, the probability will be postural hypotension. If the BP
Yeah,
is high,
high than the autonomic dysreflexia.
yeah, if the BP is high, it will be more of autonomic dysreflexia. So what is the correlation with the heart rate? If the BP is low, if the heart rate is tachycardia, then most probably it will be postural hypotension. If the BP is high and there is a bradycardia with sweating of the face, you are probably dealing with autonomic dysreflexia, which is a medical emergency. Even postural hypotension is also a medical emergency because the other moment he will be going for a vasovagal syncope. Why you have to differentiate these two? Anyway, you are going to make the patient lie down only, right? And raise the limb, right?
No, we will not raise the leg in both the conditions. Especially in the postural hypotension, we can do that, but in autonomic dysreflexia, we make the patient opposite. Just
Yes,
opposite.
that's why the management is opposite. Postural hypotension, we are dealing with a hypotension. So the BP has to be raised. So make the patient lie down and raise the lower limbs. So the lower limb should be above the heart level. So that the more blood will be going to the heart and the BP improves. But if it is an autonomic dysreflexia, in which the heart rate is low, there is a bradycardia and a hypertension, then you have to decrease the BP. So what is the immediate step you can do to decrease the BP? Make the patient sit, put his legs down. So that there will be so that there will be pooling of blood in the lower limbs. With that, so that should be the first thing. Then try to figure out the reason for autonomic dysreflexia and deal with that. If you cannot, then the patient has to be given antihypertensives. That is like ultra speed acting antihypertensives. Okay, you don't have a BP apparatus at the bedside, at the patient's home. What you will do? Being a palliative care specialist?
Check the pulse rate.
Which pulse you will check?
Pulse.
If the dorsalis pedis is palpable, the systolic BP is above 100. It's like a surrogate marker. Otherwise, also in autonomic dysreflexia, it will be like the pounding pulse. Okay. I hope everybody knows autonomic dysreflexia, but for those who are not very familiar, I'll just brief. So autonomic dysreflexia happens in the high paraplegic and the tetraplegics. So here you have a stimulus. Either it can be a full bladder, like the bladder is not draining and the bladder is full, or it can be an impacted stool, or it can be an ingrown toenail. So what happens? This sensory afferents will take this impulse to the spinal cord. The spinal cord cannot send these impulses to the brain because you have a disconnection here. There is a spinal cord injury. So whatever afferent impulse has reached the spinal cord that is going to get augmented in the spinal cord. So it will be like a loop. It will increase, increase, increase. And what happens? So with this, the spinal segments like below T6 the sympathetic outflow will be activated. So this will result in the splanchnic vasoconstriction. There is a lot of blood vessels in the abdominal cavity in the peritoneum. So that will constrict. That will constrict means a lot of blood will be coming to the main circulation. So the BP is going to shoot. Once BP is shooted, there are baroreceptors in the carotid. So they will sense that the BP is shoot. So once they sense that, they will send the impulses to the brain. So brain will try to decrease the BP. How brain will decrease the BP? It will decrease the cardiac output. It will decrease the heart rate. It will increase the parasympathetic outflow of the preserved regions. So we'll have flushings and sweating and all that. Okay, I hope you understood. So that is about neurogenic bladder. Just few scenarios which you normally see. Now coming to the neurogenic bowel. As you all know, bowel, the main supply is by the proximal supply is by the vagus, and the distal will be by the nerve organs through the sacral outflow, and the pudendal nerves will be handling the external anal sphincter. I'm not going into detail into this. So basically there is a brain involved, there is a somatic pathway, there is an autonomic pathway also. Along with that, the gut has an intrinsic system of myelinic plexus. What is this? This is a spinal cord, but what is this part? Dr. Priyanshu wants to say something, but she is muted.
Conus medullaris.
Yeah.
Conus medullaris.
Yeah, this is the conus and this is the cauda. Okay. Why cauda is important in bowel? Anything above cauda is UMN bowel. Anything above sacral outflow is UMN bowel. Okay. So any lesion above cauda. Spinal sensories are affected. Sometimes these patients will have a vague abdominal discomfort at the time of stool passage. UMN bowel, the total transit time will be increased. So when you talk about the UMN bowel, the only thing you have to think is that there is an intact reflex arc. The sacral segments are intact. So if you can stimulate the reflex arc, you can actually result in defecation. And the most common problem with UMN bowel is constipation. So UMN bowel, just think that reflex arc is intact and you have to stimulate the reflex arc. Patient may be constipated because you are dealing with a spastic sphincter also. Element bowel is opposite. So here you have a caudal or conus lesion. Internal anal sphincter and external anal sphincter tone is affected. So storage is affected. The other one, the outflow is affected. This is the storage is affected. Here also the transit time increases, but overstretching of the sphincters will happen and this will result more of a soiling. So element bowel is like you cannot hold. UMN bowel is like you cannot open. Something like that. So how do you tackle? Okay, this is the Bristol stool chart. So you can see the type 3 and type 4. The sausage with the cracks and like a smooth soft sausage. These two are the normal types. So how do you manage neurogenic bowel? So clinical examination includes mainly the perianal sensations, anocutaneous reflex, anal tone, then voluntary anal contractions and bulbocavernous reflex. Not going into any detail. I just brief on bowel program. Somebody who is like somebody who is T12 complete. We're talking about complete paraplegia. Can he be continent with his bowel needs? Yes or no? He cannot feel his bowel. Can he be continent with his bowel needs? It's an yes or no only. Okay, so to give that continence, you have to teach him the bowel program. So what is bowel program? It is a comprehensive, individualized, patient-centered program which is focused on preventing incontinence, achieving effective and efficient colonic evacuation, preventing the complications of neurogenic bowel dysfunction. So you have to have continence, should have a thorough colonic evacuation, and should not have a neurogenic bowel dysfunction. It's an individualized program and everybody has to be trained on that. So what are the components of bowel program? Diet, fluids, exercise, medications, and scheduled bowel care. It sounds very easy, but it is actually difficult to do, difficult to train. But once trained, they can do. So goals is like regular passage of stool, either on daily basis or maybe alternate days. At a consistent time, bowel evacuation has to happen, and there should be complete emptying. Stools that are of acceptable consistency. And how much time can one spend for bowel care? You should finish it within half an hour or at least 1 hour. So can give some fiber supplements most of the times. Okay, how is the bowel program of UMN bowel and LMN bowel different? UMN bowel reflex arc is present. So you just need to stimulate it. How can we stimulate? Digital stimulation. How do you do a digital stimulation? You can do a perianal stimulation sometimes. That itself may be enough. Otherwise, digital stimulation. Digital stimulation means with a gloved finger, you have to put a finger inside the rectum and you have to have a circulatory movement which is lasting maybe 20 seconds, 10 to 20 seconds. So with that, there will be a bout of defecation will happen. Maybe it will take some 4 to 5 minutes. After that, you have to repeat this procedure. So maybe this procedure has to repeat even 4-5 times for a single complete evacuation. Just need to stimulate the reflex arc and reflex oiling, reflex defecation will happen. Or you can use rectal stimulants, enemas, suppositories. Even every other day passage is fine with the UMN bowel. Need not occur daily passage also. LMN bowel with digital stimulation, will it work? Yeah, there is no reflex arc. Yeah, we are talking about a very relaxed sphincter. So what you can do is digital evacuation. To put a finger inside and take off the stools in small quantities. Okay. Then you can do bowel irrigation. Bowel irrigation is like a small enemas, like tube and balloon like thing, and in which you can either push water inside or enemas. Here, LMN bowel try every day because the sphincter tone is not there. It is very difficult to hold. So they may soil. This is just in nutshell about the bowel program. Then more advanced or more complicated things will be like electrical stimulations, colostomies, then pelvic floor sling reconstructions and anterograde enemas. Even abdominal massage will also help. So complications, they can present with bowel impactions, hemorrhoids, can have perforations, pseudo obstructions because of straining, rectal prolapse, and autonomic dyslexia. Impacted stool is one of the commonest cause for autonomic dyslexia. And some of them will be having AD while passing. Like they'll be very used to that also. So that's a nutshell about neurogenic bowel program. Now we'll talk about sexual rehabilitation. Is this significant? Do you need to know, or do we need to address this?
Yes.
Okay. In your common practice, do you really come across such questions, or what do you do?
Yes, ma'am, because many times many patients they are like they get depressed, and if they are not having any child, then this added to their depression more. So we need to have a good counseling in this condition along with our physical rehabilitation.
Okay, fine. So sexual rehabilitation, there are a lot of models. I'm just explaining two models. One is allow. So always ask the patient about their sexual function and activity. It's like asking the permission whether they want to talk. That is also there. Then acknowledge the patient problems. Then what are the problems, or like what is limiting their sexual function? What is the exact sexual dysfunction that should be identified? And that dysfunction, whatever be the dysfunction, that has to be tackled. And the patient and the physician has to work together. This is just to give you an overall idea. I'm not expecting you to go and do any sexual rehabilitation, because that is beyond your scope. That requires a lot of medications, lot of expertise in this field. But what I am expecting is that, like, if they are asking you some doubts, as a healthcare worker, you should be equipped. You should be knowing. That's it. Okay, another model is implicit, which is more commonly used actually. So implicit is, as I told, permission. Permission is the first thing. It is their individuality. It is their option whether to talk or whether to discuss. Give limited information. It's not like whatever you know. It's not like jetting out all that. Whatever they want to know, whatever their problem is, that according to that, information has to be given. Suggestions should be very specific. There should not be general suggestions. Whatever their dysfunction is, that has to be identified, and specific suggestions has to be given. And the therapy has to be intensive, and that should be by the expertise. When I say suggestions, it is not counseling. Sexual rehab is far beyond counseling when it comes to spinal cord injury. You have to actually deal with it. It is not just depression, or it is not just mental things. This is just the pathway. So you just need to know that there is two things. One is psychogenic pathway, one is reflexogenic pathway. For erection, there is two things. One is the sympathetic mediated, which is the psychogenic pathway. And one is the parasympathetic mediated reflexogenic pathway. So if you have a patient who has a T4 lesion, what will be intact in them? So in them, the psychogenic pathway will be affected, but reflexogenic pathway will be intact. So reflexogenic pathway means any stimulation in the genital region can actually stimulate the reflex erections. Psychogenic pathway is like any sexual trigger, any thought process, visual, or any emotions, anything can actually trigger the psychogenic pathway. Not going much details actually. So psychogenic is cortical activation. It is also known as erectogenic pathways. It is sympathetic mediated, and it is the thoracolumbar outflow. Reflex erection is by the cutaneous genital stimulations, and it is the sacral arc. So the sexual dysfunction or the sexual function depend on a lot of factors. The main thing is the level of the lesion, completeness of the injury, preservation of the sensations of touch and pinprick, and the integrity of the sacral arc. Yeah, will fertility be affected in spinal cord injury?
Yes.
Yes. Yes, ma'am.
Most of the time the ejaculation will be impaired. Some of them will be having retrograde ejaculation. Some of them will not be having ejaculation at all. Even if they ejaculate, the sperm quality may be poor. The sperm motility will be poor. There will be more DNA fragmentation. Basically, the quality of the sperm is less. What about female fertility? Female fertility is not so severely affected. Most of them will resume their menstruation maybe by 6 months, 5 to 6 months. But because of the hormonal factors, the ovum quality can decrease. So how can they preserve their fertility? Somebody who is a 30-year-old, just subacute spinal cord injury, he just got married. He wants to know how his fertility can be preserved. What will you say? He's just asking, is there an option? Or what should he do?
He can check the sperm count.
Okay, he checked the sperm count. That looks maybe 70%, but adequate.
There are ways to find out the penile blood circulation. If I'm not wrong, the term known as tumescent blood flow in the night is one way to find out. And may not know the term exactly.
Okay, fine, no issues.
Nocturnal.
Internal tumescence. Okay. Here we are talking about fertility. So these people may need to preserve their fertility for the future. So here we know that we are in a condition in which the sperm quality is going to decrease. So what can we do now? That is the question.
He can
Sperm bank. Sperm bank. Yeah.
So what we can offer is we can preserve the ovum and the sperm, because there is a possibility that it may go bad. So there are techniques to retrieve the sperm as well as the ovum. So with that, we can retrieve the sperm and harvest the ovum, and we can always cryopreserve this so that they can use it for future. I think I missed one slide in between. So management is like, yeah, one thing is sexual behavior therapy and counseling. Second is medications. Most of the people will require medications. So in our section, we have what we do is first we will assess, then we will give them a chance to be with the partner and see whether it is a workable option. Most of the times it will not be. Then we will start on medications. Sometimes medications will not work. We ourselves will do intracavernous injections. Sometimes it may work. Then intraurethral medication systems is another options. Vacuum construction devices and penile processes, I myself have never used actually, but these are the other options. After intracavernous injections, we will try the vibratory stimulators also. That gives them a good feel and the confidence that they can do. Just few commonly asked questions regarding sexual rehab. Do you think someone will ask whether spinal cord injury is a communicable disease? I have heard this question from rural Tamil Nadu. So what these people think is, he is disabled. If he is having a sexual intercourse with the spouse can have the same disease. So such questions can also come. So like there is no need to be, astonished by that. As you all know, it is definitely not a communicable disease. Yeah, especially when you go for Pallium India home visits, most of the people, if somebody is disabled, somebody is having spinal cord injury, they will be having a separate bed and the spouse will be, most of the times the female, will be on the floor. So their first concern is, can we share a bed? What they, I think most of the times the female thing is like, he's already disabled, should not be thinking anything else. I think it's a very common scenario, no, ma'am?
Yes, people don't even talk about it. I don't think someone has asked. Only one patient I remember asked whether I can have children. We need to have children, but otherwise we have to initiate. And as you said, whether it is spinal cord injury or any other illness, they don't share a bit.
Yeah. So if you are the healthcare worker, if you are the physiotherapist who is seeing this patient and you understand their dynamics, and if because of this injury or because of this disease, the spouse cannot share the bed, then please make them understand that normal emotions and sharing bed and all is needed actually. That they don't know. It is our responsibility to give that, disseminate that information. This is very common. Is it a sin thinking about sexual intercourse while he is disabled, especially female? So this also you have to actually tell them, make them understand that it is a common thing. For the males, the main question is like, do I have the potential for a sexual intercourse? So for that, we have to definitely do the entire sexual rehab thing and to show them what is their problem, how it can be tackled, and what are the solutions and what is his future. This you always require the spouse also. In CMC, what we do is like we always make sure that they have a sexual intercourse before they are leaving the rehab institute. We'll give them a separate room also after all the interventions because it has to be addressed. Some people ask whether reflexogenic erections, just because they are getting erections, is it a recovery? It is not a recovery. It is a normal spastic thing. Like lower limbs, you have spasticity, you are getting the reflex arc intact here. That's it. It is not going to aid any recovery. It is a natural process. So disability does not diminish the importance of sexuality to the overall quality of an individual's life. I think with that I am ending. Any questions?
Any questions from the participants? I think there were a lot of takeaway points for me. Many things we tend to not to discuss or ignore many times. We just know that this is a thing, but we don't then track back to the reason and the causes and then relate it. Any questions from participants?
Thank you for the presentation, Doctor. May I know, like in your setting, do you have Faraday stimulation for erectile dysfunction in case of paraplegia?
Faraday stimulation. You stimulate where
Right.
exactly?
Yeah, the rectal muscles for man I'm talking about.
Sorry?
For man, for erectile dysfunction in paraplegic condition. Do you have the setting
For erectile dysfunction, where I didn't get where to stimulate actually in this.
in paraplegia?
Hmm?
For a man with erectile dysfunction after suffering with paraplegia. In your settings, do you have this?
We don't do any electrical stimulation for increasing the ejaculation or erection. Vibratory stimulations to the frenulum, yes, that is for ejaculation, and sometimes it helps in erection also. And I have never heard of actually stimulating the rectal muscles for rectal dysfunction. Actually, you can explain more if you know.
Actually, in physiotherapy, we do have an option where we stimulate the pelvic floor muscles by using Faraday current. That's a low frequency current. There are different electrodes for that. For female, for incontinence, is there for man also? Is there?
For incontinence, definitely yes. Incontinence, we do that. But how does it affect the erectile dysfunction, or like which spectrum of people do you actually treat?
Yes, we do. That's what I was asking.
Which spectrum of all? Like which is it a complete, incomplete? Is it LMN, UMN? Where do you like? In which case you treat?
If you talk about LMN, there is no control and all. In upper UMN, I'm talking about. I'm not in the practice. In the reference of literature, I'm asking.
Okay, UMN. So you have a spastic rectal muscles. So you will be stimulating that muscles.
Sorry, not upper motor neuron. Sorry, lower motor neuron. LMN.
LMN, you are stimulating the rectal muscles. Okay. And that will result in what?
To have better gain in the muscle strength. If the patient is not complete, patient is incomplete paraplegic.
You are talking about bowel continence or you are talking about erection? I'm
No,
confused.
not doctor. Not about bowel continence. Bowel continence, we have got so many successful protocols. For erectile dysfunction, some literature shows that it may be helpful for stimulating the rectal muscles by using.
So for LMN erectile dysfunction, rectal muscle stimulation with galvanic current, right? Okay. Thank you. I have never heard of. I'll have a look.
Yes, if it's a lower motor neuron with complete paraplegia, then it's galvanic stimulation.
Yeah, but rectal muscle stimulation, how is it going to stimulate the penile musculature? I'm not sure actually. That is what I'm confused, because you're not stimulating any nerves as such. You are stimulating only the muscles. And you're talking about an LMN lesion. Anyway, I don't know actually. I have to read that. Thank you. Thank you for that info.
Okay. Thank you. Thank you.
Any other questions? Rajlakshmi, you had a question? Or you just unmuted by mistake, I don't know. I think today we have a case presentation from the participant side, but could not personally come. So it will be presented by our physiotherapist, Ms. Reshma. So I don't know whether we can go into the details of it, but he has sent this long back, but today he could not attend the session due to some personal inconvenience. So we'll just see how it goes, and then possibly we can discuss a few things based on this. Reshma?
Good afternoon, all. Myself, Reshma, and on behalf of Ginny, I am presenting this case. Okay. So we'll go to the presentation. Patient details: Miss XY, age is 59, male, diagnosed with incomplete quadriplegia. Presenting complaints: difficulty in eating, pain on the back, sleeplessness, hypertension, not able to do ADL activities. History of illness: on 5th December 2019, the patient was taken to the hospital after a fall from the ladder. He was unconscious at that time when he reached the emergency department and later on taken to the ICU for the observation. Patient have a history of hypertension for last 1 year. Examination: vital signs within the normal range. Pain, BPI score is 7. Range of motion: bilateral upper limb it's 70. Bilateral lower limb it is 30. Nutritional assessment: moderate, normal diet. Asia scale grade C. FIM score 26 on the motor and 35 on cognitive. Pressure soles nil. Control bladder and bowel movements. Treatment and significant investigation. First admission on 5th December 2019. ICU management, observation for 3 days. Investigations: X-ray of chest AP view, followed by CT scan, MRI to get a clear picture, blood and urine routine. Treatment: pulmonology consultation, physiotherapy consultation, neurological consultation, and discharged on 9th December 2019. Psychosocial aspects: debt of around 6 lakhs, wife is currently unemployed, he is living with his family, he has 2 daughters, both of them are still studying, she belongs to a Hindu family, he was a plumber and breadwinner of the family, poor socioeconomic background. Medications: Neurobion 40 OD, Mayoral 8 mg, Renerve Plus OD, Silcar 10 mg, Pantoprazole OD. Main concerns on physical side: back pain in prolonged sitting, pain and weakness, fatigue, difficulty in doing ADL activities. Psychological, it's being a burden, depression, and irritability. Socioeconomic, debt around 6 lakhs, poor socioeconomic background. And on spiritual side, why this happened to me, and when will I be able to walk and do my own needs without anyone's help. Summary is 45 years of male had a sudden fall from the ladder and landed on the upper back and neck, suddenly taken to the hospital. He is further diagnosed with a fracture of odontoid process and spinal cord injury, later on concluded as incomplete quadriplegia. He is unable to do his ADL and fully bedbound with physical, psychological, social, and spiritual issues. Next. Discussion points. Patient is aware about his diagnosis. Patient is curious to know more about his prognosis. When will be able to walk properly without any support? Will I be coming back to my old life? Questions are how to improve the quality of life for the patient, what can be done for the provide total care for this patient as a palliative care team. Thank you.
Thank you, Grishma, for taking this up in the last minute. I think we'll just spend a few minutes listening to the participants. You have to talk, otherwise I'm going to call the names. You have to switch on your video, please. Otherwise, I'm so sorry because I had to insist. So how will you communicate to these kind of patients? I'm sure you will be seeing this very, very commonly. Like, how am I going to progress? Am I going to be bedridden? How am I going to live my life? What all can be done? What all cannot be done? So how will you start the conversation and how will you go ahead with the treatment? Anyone?
Maybe rather on focusing on bigger goals, we will ask him to take small step each time. For example, we will work for range of motion first, then we will work to increase the muscle power and further on. So it will be like small wins to, help him to get motivated emotionally. Yeah, thanks.
Thank you, Gargi, for your comment. Yes, Dr. Priyanshu.
I think I would just like to add something what Dr. Gargi said. So basically, it is like setting up a realistic goal. So we cannot always probably work on patient's expectation. We probably might not never be able to reach as to what the patient wants. So suppose if
Yes,
if
totally
he's
agree.
asking when will I be able to walk properly without any support, so that is his expectation. But setting up a realistic goal is very important for us, and definitely we have to give the clarity to patient as to what we will be able to achieve after the treatment is done. Because if we can answer this question, when will I be able to walk properly without any support, then there's no difference between us and God then, I guess. So basically setting up a realistic goal is important to have a clarity among the patient and the caregiver as well, the family of the patient as well.
Thank
Can
you.
I add on?
Yes, yes, Dr. Nitha, please.
See, Priyanshu, the way I look is like somebody is asking whether they will be able to walk properly without support. So you have to give an answer. You cannot say that, okay, God will decide. You have to give an answer on the current evidence. Like what is the percentage? What is the prognostic chance? That is what they want to know. We don't know whether they will fit into a good prognosis or bad prognosis, but you have to give the percentages.
Yes,
Okay.
ma'am. That's what I'm so sorry. Yes, ma'am.
Continue.
No,
ahead.
actually, what I meant to say was like setting up a realistic goal is very important, wherein me and the patient, or us and the patient, comes to a mutual understanding. Okay, so basically, if you have had an injury, probably you will never have a life which you had previously, but you will definitely be able to walk with a support. That is a realistic goal. But if we give a patient a hope that, okay, you will be able to walk properly without any support, that is a false hope, I believe. And that is a patient expectation. So basically, setting up the realistic goal in front of the patient from the starting of treatment is very important, is what I feel is my personal review.
Yeah, I agree with you totally. But we are dealing with an Asia C4. Reshma, can we go back to the examination slide, please?
Yes, ma'am. It's C, ma'am, grade C.
Okay, that grade C.
Grade C.
What is the most important information that you need in this patient? Something which is lacking in this. Can anybody tell? You are talking about a traumatic spinal cord injury. You said it is an AAS grade C. What is the other piece of information that you really want to know as a physical therapist? See, for me, it doesn't make any sense you telling Asia grade C. Is he a C3? Is he a C4? It's a tetraplegia, or is he a T1? The neurological level of injury, that is the most important piece of information here. Because if you are talking about a C4, you are talking about a human being who is respiring only with his diaphragm. So the mortality rate and his prognosis is entirely different from a T1 tetraplegia. Okay. Next thing is Asia C. So if you're talking about an Asia grade C, T1 tetraplegia, the probability of he being an Asia D is almost 80%. So there is a lot of hope which you can give. We don't know whether he will fall into that 80 or will he fall into the other 20. But at least we should be able to give that piece of information. And everybody dealing with spinal cord injury, please make sure that you know the neurological level of injury. Because that is the most important and base for any intervention or any therapy or any prognostic value that is needed. Okay. Sorry, maybe ma'am can.
No. I'm not an expert in this, so I don't know. I don't know whether I'll be able to give more info.
Madam, it is said that there is a fracture in the odontoid process. So I think we can automatically find the level of injury in that person.
Okay, he can have an odontoid injury, but he can have a lower level also. So you have to examine each and every patient, and neurological level of injury has to be noted by the physiotherapist. Make it a routine. Whether you are in a tertiary care hospital, whether you are in a field, or whether it is a part of palliative care. Because the patient's life and prognosis depends on single diagnosis of that. Asia C is the second part. First is the neurological level. Okay.
And I think each plan depend on that, right? The
Yeah.
bowel, the bladder, and the sexual
Everything.
dysfunction. Everything depends on the neurological level of injury. I think that's very important takeaway point. Any other questions from the participants?
Maybe we can put that question slide, Reshma.
So again, how to improve the quality of life and what can be done to provide total care to patient. What do you think, others? What do you think can be done for this patient? You've seen his family. What kind of? I'm not sure whether this is a he or she, because some places it's he, some places it's she. But yeah. But how can we help the family or the patient to have a decent quality of life? Any other points from you?
Maybe any sort of vocational training, because he won't be he won't be able to do his actual professional job which he was doing before. So maybe any sort of vocational training to him or his wife can be done.
Thank you, Garni, for the response. Very valid point. And Dr. Nitha, I would like to ask about the possibilities of intermittent catheterization for these guys. Sometimes the partners are willing to do for the patient. Sometimes it happens that we want to do something on our own. So, what would you recommend from your side?
You're asking about this case, or ma'am, are you asking whether attendance CIC is needed or not?
Whether it can be done by the attendant in general, do you encourage that, or is it? And for the females, they find it difficult. They need someone support to sit up and place a mirror and then hold the leg. So I've seen personally that it's very difficult for females in our setting, and they tend to give up. And many a times partners may not be willing to do it for the female, but sometimes the wives are willing to do the catheterization for the patient. Will that serve the purpose after all?
Personal opinion, I will never ask an attendant to do. Unless it is a meningomyelocele and a small kid and the mother is doing. Because it is like every 4 hours you are asking someone to put a tube in someone else's body and take out the urine. It's like tying something. That's what I feel. So rather than attendant CIC, it is better to be on a continuous bladder drainage if the patient cannot do. For all my tetraplegias who has no hand function, I'll prefer a suprapubic catheterization over anything else. That will be an accepted route.
Just the reason for suprapubic for this, just for the sake of discussion, you just told you preferred suprapubic.
Yeah, suprapubic is the infection rate is less because you are not touching the penile urethra and the prostate things. And for sexual things, if they want, the sexual pathway is free, and it is easier to manage actually the suprapubic catheter. The chance of ulcerations, fissures, and all is very less. Infection rate is also less. So tetraplegics always prefer suprapubic. If they cannot, if the hand function is not good, if they can put themselves the tube, then definitely CIC. Attendant CIC, I've never asked to do. There are people who actually say, but I personally don't prefer that. And we don't have much literature support to say that, okay, this is good and that is wrong, like that. It's a personal choice. And as you said, ma'am, females, most of the times when the husband and the wife is ready to do, but the ulta way, they will not be ready to. But I never ask because I don't think that is needed.
We had a few instances where the caregiver or the partner was doing the CIC for, and sometimes it's a patient's feeling that I'm burdening them too much. Already they are being burdened. Now they have to come every. And personally, as you said, I don't feel it serves a purpose because the caregiver has to. The patient is not independent per se. Totally dependent every 4 hours. They cannot travel, go for an outing without the partner. Yeah, so I just wanted to ask your opinion about it. Are there any other questions from the participants? Everyone is silent. When you get the assignment, you will have to go back and listen the session again, those who have not spoken or heard this today's lecture. So, yeah. I think, Dr. Nitha, we can wind up today's session. I don't think there are much questions from their side. Thank you so much. I learned a lot. And I would want you to take the session for us once again, because there were a lot of practical stuff there, not much of theory, but things that we really need to know. It's precisely what we need to know. There is nothing to omit. So that's wonderful. Thank you so much for agreeing for the session. Thank you so much.
Thank you all. Thank you, Dr. Nitha.
Thank you, ma'am, and thank you all actually for this patient listening and getting interactive sessions. And thanks for inviting me for this. Thanks a lot.
Thank you, ma'am. Thank you so much. And I have shared the feedback link with you all. Please go through it and fill it up. We'll see you on the next class and bye.